Hi, my name is Darshan Patel. I'm an internal medicine resident at the University of Louisville, and I'd like to present a case of a metastatic myxoid sarcoma with pericardial invasion that was diagnosed at our institution. This was a 30-year-old male with no past medical history who presented to our ED with chief complaint of cough and shoulder pain. Chest x-ray at the time showed cardiomegaly with an ovoid opacity obscuring the right heart, and EKG showed nonspecific low voltage changes. Several hours into his ED course, he underwent PEA arrest, and ROSC was obtained in about 2 minutes. Point-of-care ultrasound showed a large pericardial effusion, which was emergently tapped. He was subsequently stabilized, transferred to the ICU, and we began workup for a presumed pericardial mass. This workup included cardiac MRI and CT scan, both of which are shown in figures 3, 4, and 5. Showing a large, approximately 10 by 10 mass effacing the right atria and invading through the pericardium. Fortunately, interventional radiology was able to biopsy the lesion, and pathology confirmed it to be a high-grade myxoid sarcoma. Unfortunately, a specific subtype nor origin could be readily identified. CT surgery was brought on board, and they were able to resect a majority of the mass, all but about 1 centimeter that was left adherent to the IVC. And over the next 10 months, the patient underwent 8 rounds of chemotherapy, but unfortunately, disease continued to progress, and patient eventually succumbed to his disease approximately 12 months following diagnosis. This case is interesting because it helps demonstrate some important concepts about secondary cardiac tumors, and one of them being that they can present in a myriad of different ways. Most secondary cardiac tumors present with some combination of pericardial effusion, arrhythmia, heart failure, and obstructive or embolic phenomenon. Additionally, secondary cardiac tumors are not as rare as we once thought. In fact, they've been found in up to 20% of patients with known metastatic disease. Therefore, having a higher clinical suspicion, especially with known cancer patients, can help lead to earlier diagnosis, earlier treatment, and potentially prolonged survival.